for your storm to settle as I look toward this.
Hello everyone and a very warm welcome to this next big mega chapter of immunization. This is one very important topic which has been asked so many times in the exam, and usually it is said that this topic, this chapter has a 100% strike rate. So that was from MCQ point of view. Talking from a doctor perspective. See, we are always talking of a big country like India, where we are talking of 140 crore population, where 67,000 children are born every day, which comes out to be 2.5 crore children which are born every year. And the government of India is obliged to give a primary level of protection. That is what is immunization, right? So that is the right to health. So each child will have a right to health. If you might be the biggest cardiologist in the town, you might be the biggest intervention cardiologist, radiologist, gynecologist, whatever it is. But if the helper who's working in the home and they say that, sir, madam, can you tell me my daughter is or son is 7 months of age, what are the due vaccines? Or my daughter's son never got vaccinated, what are the due vaccines which we should give? If you don't know the answer, then you are no more a doctor in their eyes. So to be a doctor, you need to understand the points about immunization. From your MCQ perspective, I have divided this whole chapter on immunization into 3 broad categories. We will talk about some of the basics in immunization. Then we will switch over to some of the more important topics from MCQs regarding the public health system of immunization. We need to talk about the national immunization schedule. Then about the cold chain, waste management, adverse events following immunization, and some of the calculations regarding vaccine calculations. Then we will try to sum up the chapter using some of the other vaccines and the strains. So now come over to the basics of immunization. The immunities can broadly be classified into active immunity or passive immunity. You can very well understand this. Let us say we are talking about the food that we make in our kitchen. Either we can learn how to make a food dish, or we can order the food from outside using some of the mobile applications, delivery mobile application. So if you order a ready-made food, that is the ready-made antibodies, that is called as the passive immunity. Whereas if we learn how to make the antibodies, so it is active immunity is developed either after an infection. This infection could be a case, or it could be a subclinical infection, or after a vaccination. That is what is active immunity. So your body actually learns how to make the antibodies. So that learning process is active immunity, and if you get the ready-made antibodies, that is passive. Let us have a few words about the active immunity. If you talk about active immunity, active immunity, it can broadly be having 2 types of immune responses. We can have a primary immune response, or we can have a secondary immune response. If you talk about the primary immune response, okay, so the primary immune response is something like you're learning how to make the dish, right? So let us say that you're making the dish for the first time. So the primary immune response is the immune response by the body, which it gives for the first time when it sees the antigen. So on the first exposure to antigen, that is what is the primary immune response. So talking about this primary immune response, if you talk about the primary immune response, in the primary immune response, the body will make some antibodies. So within 3 to 7 days, it starts making, let us say this was the point of exposure, and within 3 to 7 days, it starts making some of the IgM antibodies. It starts making the IgM antibody. That is the first antibody the body will start preparing. And then very soon, in 2 to 7 days, it starts preparing a IgG antibody, which is more in number than the IgM, and it stays for a slightly more longer time. So just 2 MCQs over here, beta, which is the first antibody to appear? The first antibody to appear is the IgM, and which is having a more pronounced action, which is more in quantity and more in half-life, in life of the antibody, please note it is the IgG. The subsequent antibody by the body is known as IgG. This is called as the primary immune response. The IgM antibodies will start happening within 3 to 7 days, and IgGs will happen after 2 to 7 days. 2 to 10 days, like you can say that 2 to 10 days, the IgG antibodies will start developing. So that is what is the primary immune response in the active immunity. Now, let us say that you are making the dish for the first time. If you're making the dish for the first time, you'll take some time to make the dish. But when we ask you to make the same dish next time, the time taken by you will be much lesser because you know what is going to happen. So in this primary immune response, there already has been sensitization to the body. The body is sensitized to the antigen. That means there is some formation of the memory of the antigen. So there is a training of the reticuloendothelial system. Training is there, and there is formation of the memory T cells. There is formation of the memory T cells, or the reticuloendothelial system kind of trained. So now after the primary immune response, if the antigen comes back again, so now in case there is a repeated exposure, to whom? To the antigen, of course. So if there is repeat exposure to the antigen, the time taken by the body to show that same IgMs and IgGs will be much lesser. So there is a rapid antibody response. There is a rapid antibody response, and the antibody production is more in abundance. It is more in quantity compared to the primary immune response. So that's actually the reason that why do we give the first dose and the second dose and the third dose of the vaccine. That is that we want a secondary immune response by the body to be more pronounced. So that is what you understand by active immunity. You can have two types of immune responses, the primary immune response or the secondary. The secondary is on repeated exposure, the primary is on the first exposure. Another concept for you to remember for your exam is in the active immunity only, that there is in active immunity only, that there is two types of response. One is primary, secondary immune response. There is another funda for you to know that there could be a humoral antibody production, there could be a humoral response, or there could be a T cell mediated immune response. Beta, the T cell mediated immune response is also called as the cell mediated immunity. This is the cell mediated immunity, and humoral immunity means the formation of the antibodies. What are the antibody classes? Basically, we are talking of the immunoglobulins. So the formation of the immunoglobulins, that is what is humoral. And who will make the immunoglobulins? You must have heard about this much more in detail, much in depth during your microbiology sessions with Dr. Shivika ma'am. And that is, you must have excellently understood about the humoral antibody and the cell mediated. But just grossly, please note who develops the immunoglobulins. It is the B cells which are going to make the immunoglobulins, and the cell mediated immunity is by the T cells. And usually it's always a combined response. The B cells work in conjugation with the T cells, and they both help in development of the active immunity. Active immunity could be of two responses. You can have a primary immune response, or you can have a secondary immune response. So that was about the immune responses, and that was about the active immunity. Talking a little bit more in detail about the immunoglobulins. If you talk about the immunoglobulins, what are the points for you, salient points for you to remember for from a public health point of view, basics in immunity? So IgM is usually around 6% of the total immunoglobulins. This IgM is the first antibody to occur. It is the first antibody formation which happens, and usually the half-life of this antibody is roughly around 7 days. If you talk about IgG, it is taking care of the most of the immunoglobulin production. It is 80% of the total antibodies. It is the subsequent antibodies subsequent to IgM. And please note that IgG antibodies, they are very small molecules, not very small, they are smaller molecules, and they can cross placenta. So they cause the maternal transfer of antibodies. So the mother to child via placenta. So they can cross placenta. Via placental transfer is the IgG antibodies. The half-life is typically long, around 21 days, 3 weeks. If you talk about IgAs, the next in line is the IgAs. IgA are roughly around 13% in the total, out of the total immunoglobulin load. IgAs are more in body secretions. Please note they are more in the body secretions like milk or sweats or tears. So that is more in body secretion. Just remember this. And that's the reason we say that colostrum is rich in which antibody? It is very high in mother's milk, especially colostrum. So colostrum is rich in the IgA antibody. The half-life is ranging around 7 days only. So 6 to 7 days is for IgA and IgM. But IgG, it stays in the body for a longer time. IgE, IgD, they are very less. They are usually less than 1 to 2% of the total load of the antibodies in our body. IgE is predominantly responsible for allergies or allergic reactions, and they have shorter half-lives. So that was just a very brief about the immunoglobulins. So next in line, let us have a few words about the passive immunity. Beta, the passive immunity is by ready-made food. Please note that there is no training. There is no training of the reticuloendothelial system. We already did this. There is no training of the reticuloendothelial system. There is no formation of the memory T cells. So how are you going to, this is a ready-made antibody. How are you going to give the antibody? Anyways, you leave aside how you are going. The point is, if I give you a ready-made antibody, will there be rapid immunity? Of course, there is a very rapid immunity. There is a rapid immunity which it develops. It is almost not rapid. We should say it's immediate immunity because you're giving a ready-made antibody. You give the antibody, it starts the immunity in the body, right? So it's a rapid, or almost you can say immediate immunity which happens in the body. Will it be there for the whole life, or will it be there for few months or years? Do you think so? Answer is no, because there is a limit for the half-life. You remember the half-life of immunoglobulins? So there is a limit of half-life. Whereas in the active immunity, you remember there was training of the memory T cells. So the memory T cells have been trained to recognize the antigen and give antibody. So in active immunity, it is more prolonged immune response. Like, it's not a prolonged immune response. Your body is trained to find that antigen again and again. Whereas in passive immunity, please always note that it is a temporary immunity. So how can we give you a passive immunity? What is the way to give you a passive immunity, beta? The passive immunity, I can induce in your body using only two obvious things. I can either give you immune globulins, that is the human immunoglobulins, or I can give you non-human immunoglobulins. I don't say immunoglobulins. These are generally, we don't say immunoglobulins because we think that the immunoglobulins are the things which are produced by your body, by your B cell after immune response. These are immune globulins. These are ready-made in other people, and we take them and we give it to some other people. So immune globulins, that is the human immune globulins, or we can give non-human immune globulins. These are called as anti-sera. So either we can give human immunoglobulins or we can give non-human immune globulins, that is anti-sera. If you talk about the immune globulins, the immune globulins can be used in various conditions. Like we can give it for hepatitis A, B, C, rubella, varicella, measles, rabies, tetanus. So there is the dosage, as you can see over here. Hepatitis A is predominantly given in cases of whom? Like, to whom will you give them? We are going to give them in cases of travel. So people who are traveling to endemic areas, you can give hepatitis A immune globulins because it is going to give you a short-term immunity. You don't need a long-term immunity. Hepatitis B immune globulins are extensively used, and they are in fact recommended all the time. Where do we recommend hepatitis B immune globulin? It is given in cases of, you might have heard it during your session in hepatitis B, that it is given in cases of post-exposure prophylaxis to needle stick injury. Immune globulins are also given in cases of newborns born to hepatitis B positive mother. So in those cases that the child is exposed to hepatitis B, we are going to give the hepatitis B immunoglobulin. They are very much recommended. Same is true for hepatitis C. It is recommended in case of needle stick injuries with known exposure and in case of newborns born to hepatitis C females. Rubella, it is kind of more optional. Rubella immune globulin you would like to give when a pregnant female, a female who is pregnant, was exposed to rubella, and that too in the early phase of the pregnancy, because in the later phase of pregnancy, we consider that rubella, even if it happens during pregnancy, it's not so dangerous as it happens in the early stage of pregnancy. Why? Because you're scared of the CERS, that is the congenital rubella syndrome, because the rubella virus can travel through the placenta in the early phases of pregnancy. So in early pregnancy, we might think of, it's kind of optional, depends on the load of the viral load or the closeness of contact with the rubella exposure to the pregnant female. So in early pregnancy, we may think of giving a rubella immune globulin. Next in line is varicella, zoster, and measles. They are given to whom? They are given in all cases of newborns who are exposed to these particular viruses, and in cases of immunocompromised children, you are going to give them immune globulin in case you feel that they are very immunocompromised and they cannot take up vaccine. In those cases, you're going to give the immune globulins. Rabies, I think we all know it. Rabies immune globulin is given in what case? You must have heard it during your lecture in rabies. We discussed it much extensively that rabies beta, when do we give? Immunoglobulin, when do we give? The rabies immunoglobulin is given in all category 3 bites or class 3 bites. It is also given to immunocompromised people, patients who are immunocompromised, to class 2, immunocompromised, and class 2 and class 3. So in case of normal individuals, to all class 3 bites, they will get the rabies immunoglobulin. And in case the person is immunocompromised, to both class 2 bites and class 3 bites, you're going to give the rabies immunoglobulin. Talking about the tetanus, tetanus is given in the dose of 250 international units, and it is given as intramuscular injection. It is given to unclean wounds. In case of unclean wounds, contaminated wounds, and the patient was unimmunized. So for tetanus, we are going to give the intramuscular injections. It is given as intramuscular injection, and the effect for tetanus immune globulin will last for around 3 to 4 weeks, nothing more. So these were some of the human immunoglobulins. Next in line could be some of the non-human immunoglobulins. Non-human immunoglobulins, these are called as anti-sera. So anti-sera could be there for many diseases. Like if you just talk about rabies, for rabies you already have learned that there could be a rabies human immunoglobulin which is given in the dose of 20 international units, and you also have for rabies equine. Equine means it was produced in horses, so we can give a horse immunoglobulin. Of course, the human is much better than the horse. In India, what we are using is the human immunoglobulin and not the equine immunoglobulin. Diphtheria, if you just talk, there can be one MCQ that diphtheria immunoglobulin, the anti-sera, you're giving to whom? Please note that diphtheria anti-sera can be given to all cases to close contacts of severe diphtheria cases. So we might give the diphtheria antitoxin or the anti-sera in tune of 500 to 1000 international units. It is given as intramuscular injection. Similarly, for tetanus, you have the human immunoglobulin and the equine. Of course, in mostly it is human immunoglobulin which is more preferred. It is always the human immunoglobulin which will be more preferred. Then you have also for the Clostridia infections, the Clostridia botulism and the Clostridia perfringens or the Welchii, which may cause the gas gangrene. So we have availability of these immunoglobulins as well. So that was just a very quick brief overview about what is active immunity and what is passive immunity. Next in line, the next topic is what are the types of vaccines. Beta, if you talk about the types of vaccines, which could be a live vaccine or broadly it could be a killed vaccine. There are two broad categories of the vaccine. So how do you make, let us say you are Dr. Sabin, or you are any person who invented any live vaccine. If you want to invent any live vaccine, how will you invent a live vaccine? We will take a virus or a bacteria or a pathogen. We will do serial cultures. They are done cultures again and again and again to lose their what? To lose their virulence or pathogenicity or immunogenicity. Please note, we will make the antigen or we will make the organism to lose its virulence and to lose its pathogenicity. But in the live vaccines, you retain, serial cultures are done to retain what? They are done to retain the immunogenicity. They will retain the immunogenicity. That means what? That means they are going to retain the capacity to induce an immune response in your body. That is what is attenuation. This is what is attenuation. These are what are the live vaccines. And on the other hand, you can have a killed vaccine where you take the organism and you just beat it very hard so that it loses the outer shell and it dies. So basically in killed vaccine, you are going to kill the organism. Usually we kill the organism using chemicals. Most commonly used chemical is formalin. It is a killed vaccine. These are most commonly we use formalin. We can use other chemicals to kill it. And we just take the outer shell or the organism of the body, and now it has lost it. There is no chance of multiplication, multiplicative capacity. There is no multiplicative capacity. So therefore, it is said that the killed vaccine in the body are not going to lead to such a big immune response as a live attenuated vaccine would have, because the live attenuated vaccine will enter into our body, not cause a disease, no pathogenicity or no virulence at all, but there is immunogenicity and they are going to multiply. So the immune response is in fact much more than the killed immune response. And then there could be some other vaccines, some other third category of the vaccine which are not live, not killed. They are synthetically manufactured vaccines. These are synthetically manufactured vaccines, that is the subunit vaccines, where you take some portion of the virus or the bacteria or the fungus or whatever we are dealing with. So let us have a few words about what are the live vaccines. If you would like to remember for your exams what are the live vaccines, you can remember this as every boy would love crime types of serials, right? Or crime types of episodes on different these OTT platforms. But boy loves crime types. So you can remember it as BCG. O stands for oral polio vaccine. Y is yellow fever. Loves means live vaccines. So live vaccines is what is love, right? And then you have the crime, that is chickenpox, R rubella, I influenza, M is for measles and mumps, and E is for encephalitis or the Japanese encephalitis, which is the live vaccine. And types, you can remember it as typhoid. So that is what is, you can remember most of the commonly asked live vaccines. Please note these are the live vaccines. Now, on the other hand, if we talk about the killed vaccine can again be of many examples. You can have killed vaccines like Japanese encephalitis. There is a killed vaccine also. It is called as the Nakayama strain or the Beijing strain, which is a Japanese encephalitis killed virus. You can also have a pertussis killed vaccine, and these are like primarily, I would like to have 2-3 points about the killed vaccine. You can just write it down in your copies that in killed vaccine, please note that the organism cannot multiply because it is killed. It cannot multiply in the body. So there is no genome of organism which is injected. It is always less efficacious. And because it is less efficacious, therefore, usually 2 or more doses of the vaccine will be required. But there is an typical advantage about the killed vaccine. See, the live vaccine can enter into the body and cause and have multiplication. I already said that in the live vaccines, we are going to do serial cultures and finish off their virulence at all, and also the pathogenicity. But there might be some people who are immunocompromised. If they are immunocompromised, maybe a higher dose of live vaccine, or maybe the normal dose of live vaccine, which does not cause any disease, a normal person may cause a disease, and therefore that is the disadvantage of a live vaccine. It is contraindicated in severe immune compromise. It is contraindicated in severe immunocompromised status. It is contraindicated in severe immunocompromised status, the live vaccine. That is the distinct advantage of a killed vaccine. The advantage is that it is not contraindicated in immunocompromised. It is not, in fact, it contraindicated. In fact, the killed vaccine, they have very less contraindication. The only contraindication that you can think is probably because of some of the effects of the vaccine per se, or there could be anaphylaxis. But the live vaccine, it is mostly contraindicated in case of allergies or anaphylaxis and immunocompromised status and pregnant status. So you would like to not give the live viruses. So the next one is about the toxoids. If you talk about toxoids, MCQ is that some of the organisms, they might be secreting some exotoxin. The exotoxin, if it is taken up and the only exotoxin part of the virus or the bacteria is injected inside, that is what is the toxoid vaccine. So the toxoid is, of course, not with the viruses but only with the bacteria. The toxoid, you can use it for diphtheria, or we use it for tetanus. So you can have these tetanus toxoids or the diphtheria toxoid. Next in line is the protein vaccine. The protein vaccine is something similar to the toxoid, but the toxoid is like you're taking the exotoxin, but you take any protein subunit of the organism. The example of protein subunit vaccines could be influenza vaccine. The pertussis vaccine, I told you, is a killed vaccine, right? So in the killed vaccine, you're taking the organism and you're beating it so hard so that the genome is outside and only the outer shell is left inside. So that is a killed vaccine. In the protein subunit vaccine, we will take the outer shell. Out of that outer shell also some of the specific proteins are taken. So that is acellular pertussis vaccine. Many times students get confused that what is acellular pertussis. Please note, acellular pertussis is a protein type of vaccine. I think many of you must have heard about the Novavax. Have you heard about the Novavax? Novavax is a COVID vaccine which takes only the spike proteins of the COVID-19 virus, and that is injected inside. So if you take only the protein component of the COVID-19, that is what is the Novavax. So that is about the protein subunit vaccine. And the next is polysaccharide vaccine. Polysaccharide vaccine, in a polysaccharide vaccine, let us say this is the organism and this is a killed organism. Now in the killed organism, if you just take the outer capsular polysaccharide, so some of the organisms will induce the disease or the immune reaction in the body with their capsular polysaccharide. If you just take the capsular polysaccharide and only do injection of that only, that is technically called as a polysaccharide vaccine. The problem with the polysaccharide vaccine is that it has to be only serotype specific. It has to be a serotype specific because you're not giving the whole organism. So you're just giving one portion of the capsular polysaccharide. That is one of the disadvantages of a capsular polysaccharide, that you will have to take all the serotypes, take all their capsular antigen and then mix them into a single vaccine and then give it. So that is what is a capsular polysaccharide vaccine. It is serotype specific. Example of polysaccharide vaccine can be, we are giving the HIB, Haemophilus influenza B vaccine. The polysaccharide vaccine could be also a typhoid polysaccharide vaccine. You must have heard it during your session on typhoid about the typhoid polysaccharide vaccine. The polysaccharide vaccine could also be for the pneumococcal disease. We can have the polysaccharide vaccine. Next is, what is this glycoconjugate? Glycoconjugate is something similar to the polysaccharide. See, what happens is that in some children, in some children, if you give a polysaccharide vaccine, it is not going to induce the immune response because you are giving a polysaccharide portion only, and it is serotype specific, and children are not able to age less than 2 years or 1 year. They are not very much able to have a immune response. So what we can do is we can take out this polysaccharide. So you take this polysaccharide out, along with that you put some extra protein molecule. So you conjugate with the protein molecule. If you conjugate with a protein molecule, which could be any amino acid, it could be albumin, globulins, any protein molecule, which makes it more easy to enter and induce an immune response even in children. So the conjugate vaccine, the advantage is it has more immunity. It is usually beneficial in young ages, very age less than 2 years, it is beneficial. So that becomes a disadvantage of a polysaccharide vaccine. Polysaccharide vaccine cannot be given to age less than 2 years. It cannot be given to age less than 2 years. It is only given after age of 2 years. Before age of 2 years, if we want to give the polysaccharide vaccine, that can be given as a conjugate vaccine or a protein subunit vaccine or a protein component conjugated with the capsular. So what are the examples of the conjugate vaccine? You can remember that the conjugate vaccine is similar example. We have a conjugate vaccine of the pneumococcal vaccine, which you already know. We give the pneumococcal conjugate vaccine, that is the PCV, we are giving in the national program. There is also a conjugate vaccine for the meningococcal vaccine. Meningococcal vaccine, that is the ACW135 and Y. That is what is the quadrivalent vaccine, ACW135Y vaccine. And that's all about the conjugate vaccine. Again, please note that the polysaccharide vaccine and the conjugate vaccine, they have to be very much serotype specific. That's what is one of the disadvantage. And next is, what are the recombinant vaccine? What do you mean by the recombinant vaccine? Any antigen, if you take and you culture the antigen on yeast or any host. So you take the antigen and you culture on yeast or any host, and then you just amplify the antigen. So it's kind of a more synthetic vaccine. That is the recombinant vaccine. We do have recombinant vaccine for meningococcal vaccine, recombinant vaccine for the human papilloma virus vaccine, that is a recombinant type vaccine. We have the cholera toxin vaccine, that is the Dukoral and the Sancol. These all are recombinant vaccine. Please note that all these that you have done over here, the toxoids, the proteins and the glycoconjugate vaccines, the polysaccharide vaccine, the recombinant, they all are types of subunit vaccine. So just to summarize, what you have done is that if you talk about the type of vaccine, it could be a live vaccine, or we can have a killed vaccine, or we can have the subunit vaccine. The subunit vaccine could be of many types. You can have the protein subunit vaccine, we can have the toxoid subunit vaccine, we can have a polysaccharide vaccine, we can have a conjugate polysaccharide vaccine, we can have a recombinant vaccine. So all these are called as the subunit vaccine. They are synthetically prepared vaccines. Killed vaccine, you take the vaccine and you beat it so hard that the genome is not there. You usually kill it using formalin, and live vaccines we insert it using the attenuation process or do serial cultures. So that to please remember, this is a frequently asked MCQ, that in live vaccines you finish off what? You finish off the virulence. You can finish the pathogenicity also, but predominantly, like the main hardcore thing, most important thing is you finish off the virulence and you retain what? You retain the immunogenicity. What is virulence, betas? Virulence is the killing power of disease. So you finish off the virulence and you retain the immunogenicity. Beyond this, a few other types of vaccines you can remember that there's no MCQ on this. These are called as the mixed vaccines. What do you mean by mixed vaccines? Where you take different types of vaccines, you can combine diphtheria, pertussis and tetanus. What is diphtheria and tetanus? These are the toxoids. What is pertussis? Pertussis is a killed vaccine. We can also use the acellular component. What is the acellular component of the pertussis? That is the subunit vaccine. So you can take the subunit vaccine, or you can take the killed vaccine and combine it with the toxoid. So that comes as the mixed vaccine. We can also have the pentavalent vaccine. What do you mean by the pentavalent vaccine? Pentavalent has penta. Penta means 5. So it talks about the D, P, and T, plus the H influenza B, that is the Haemophilus influenza B, that is H influenza B, plus it also has the hepatitis B vaccine. So all these are called as the mixed type of formulations or the mixed vaccines. Then as sometimes the examiner may ask you, what do you mean by a freeze dried type of vaccine? Beta, this could be your frequently asked a Viva question. What do you mean by a freeze dried vaccine? So basically, freeze dried vaccine, these are the powder form of vaccines, and because these are powder form, they have to be reconstituted. They have to be reconstituted. Reconstituted with what? They have to be reconstituted with diluents. So what are the diluents that you're going to reconstitute? You can use normal saline. We can use any distilled water. We can use any buffers to reconstitute. So the different things would be there for reconstitution for different freeze-dried vaccines. The problem is that this vaccine was produced in a powder form. Because it is there in the powder form, you reconstitute it. Because you reconstitute it, don't you think that there could be chance that you're injecting something, there could be chance of risk of contamination? MCQ, what is the risk of contamination? Which microorganism? We are talking of the staph contamination is the most common contamination which can happen. And because there is risk of contamination, we need to, once you reconstitute, you need to use the vaccine on the same day. Because if you keep the vaccine after reconstitution, then it's going to be bekar, it's going to be destroyed because the reconstitution could lead to contamination. So please note that in the freeze-dried vaccine, which could be the freeze-dried vaccine, the BCG is a powder form vaccine. The measles is a powder form vaccine. The JE is a powder form vaccine, and you reconstitute. Please note that BCG and measles, they should always be used within 4 to 6 hours. If you get the single best answer, please mark 4 hours. 4 hours is what the guidelines will say. So the measles and the BCG vaccine, if reconstituted, they should be used within 4 hours. Japanese encephalitis is one of the vaccine which, if reconstituted, should be used within 2 hours. So that is what the guidelines will say about the reconstitution, and these are what are the freeze-dried vaccines. So as we proceed, we already talked about the immunity types, active, passive. We talked about the vaccine types, live or killed, and other subunit or the protein vaccines. And now let us talk about the vaccine constituents. If you talk about the vaccine constituents, they can be different constituents like what are adjuvants, excipients, stabilizers, or preservatives. Please note that if the question talks to you about the adjuvants are always immunoboosters. They will increase the potency of the vaccine. Examples for adjuvants, you can remember just 2 or 3, you can remember that very frequently they've asked about AS01. What is AS01? It is an adjuvant which is used in the malaria vaccine. Adjuvant is used in the malaria vaccine. Then AS03, AF03, they are predominantly AS03, AF03. They had been used in the influenza vaccine. Then AS04. AS04 is one of the adjuvant which is used in the human papilloma virus vaccine or the hepatitis B vaccine. Alum is one of the most commonly used adjuvant. It is there in almost many vaccines, the pentavalent vaccine, the DPT vaccine, and it contains, alum is the one which contains the aluminium hydroxide. So aluminium hydroxide which is used in the shake test. So alum is a pentavalent DPT vaccine. It's also there in the pneumococcal conjugate vaccine. It's there in many freeze sensitive vaccines. You can just remember it this way. What are excipients? Excipients, please note MCQ, these are inert substances. Inert substances means that they do not have any immunological effect. Excipients, these are inert substances. They have to be added from the manufacturer side, that is at the manufacturer level. They will be added. So they always are there with the vaccine. Next is, what are these stabilizers? Stabilizers means some of the chemicals which are going to stabilize the vaccine. See, vaccine has to be transported. So we add stabilizers to prevent what? To prevent the chemical reactions. If you want to prevent the chemical reactions, to stabilize the vaccine so that vaccine does not stick around, there is some chemical reaction and it does not precipitate, or it does not stick to walls of the vaccine vial. So that is what is the stabilizer. Stabilizers are usually proteins. Usually proteins are added at stabilizers, like the albumin is used as a very commonly stabilizer. Then you have the gelatin. Gelatin is used as stabilizer. Globulin is used as stabilizers. Albumin, gelatin, globulin, these are used as stabilizers. The preservatives, these are the substances which are going to increase the shelf life of the vaccine. So the shelf life of vaccine can be increased by various preservatives like thiomersal. We can have phenoxyethanol or phenols. Please note that thiomersal is no more used. Most commonly, however, used is phenoxyethanol. Some of the other constituents of vaccines can also be asked in your exam, like what do you mean by the buffers, the diluents, the emulsifiers, and antibiotics. Buffers. So see that many times the vaccine will be given inside the body and it may be affected by the pH of the body. So buffers are used where the vaccine is inhibited by the pH. So it basically inhibits the action of pH on vaccine. The example for buffers can be asked in your exam. Please note that in cholera vaccine, there is a subunit B. In the cholera vaccine, there is a subunit B toxin. So now this B toxin, subunit toxin, it is a chemical, it is a toxin which is destroyed by the pH by the gastric pH. So in cholera, we have to give a gastric buffer. Why the gastric buffer is required? It is required because the B subunit toxin is there. Please note, this is the gastric buffer which is there in the Dukoral vaccine. Dukoral vaccine, we use a cholera gastric buffer. Buffer can also be used in the Japanese encephalitis vaccine, that is the SA 14-14-2. It is a live vaccine and we need a buffer. Why? Because the JE gets destroyed by the blood pH also. So there is a buffer, that is a phosphate buffer. There is a buffer, that is a phosphate buffer. Most commonly we use buffer, which is used in most of the vaccines. This is sodium chloride is used as the buffer for most of the vaccines. Please note that the buffers will maintain the osmolarity of the vaccine in different pH conditions and stop it from getting degraded by the action of pH. So please note, you have read about the Japanese encephalitis and the cholera buffer in this particular example. Diluents. What are diluents? Diluents are basically used for the freeze-dried vaccines. So for freeze-dried vaccines, we use diluents. MCQ can be asked about the diluents, that in measles vaccine, what is the diluent? Please note M for measles and W for water. So that's the mirror image, right? So M for measles and W for water. So in measles, you are going to dilute what? You're going to dilute water. Which water? Not the normal water. We are going to use the distilled water. Distilled water is the diluent for measles. Next, they can also ask about the BCG vaccine. What is the diluent for BCG vaccine? Please remember, it is normal saline. What is the vaccine diluent that we use for Japanese encephalitis? It is a phosphate buffer. So these are some of the diluents which can be asked in your exam. So basically, diluents are used to make the powder formulations into the liquid formulations. What do you mean by emulsifiers? See, emulsifiers are something which are going to stabilize the vaccine and decrease the surface tension. They decrease the surface tension. So they are something like stabilizers. So emulsifiers are actually like stabilizers. So what are very commonly we use a emulsifier? What are the examples of emulsifier? One very commonly you must have heard, that is polysorbate. Polysorbate. sorbate. Another emulsifier you must have already heard, that is the tween 80. Do you know that in tuberculin test, what is the thing that we inject? We inject a purified protein derivative. This purified protein derivative PPD is with a tween 80. What is tween 80? That is actually a emulsifier. So please note that these are some of the emulsifiers which can be used. They actually decrease the surface tension and they act somewhat like stabilizers. Stabilizers per se, if you get a question, stabilizers, what is the main mechanism? They inhibit the chemical reactions and they maintain the stability of the vaccine, because the vaccine has to be transported in different situations, in different temperatures also. And emulsifiers, what are they going to do? They decrease the surface tension. What is the role of antibiotics? I think we all know that because vaccine is given inside the body, they usually are combined with some of the antibiotics. MCQ can be asked about antibiotics, different antibiotics we can use. Neomycin. So neomycin is there in which antibody, which vaccine? Please note it is there in the varicella vaccine. Neomycin is also there in the MMR. Very recently, all the vaccines that are there in MR vaccine or the measles vaccine or the MMR vaccine, they almost always contain neomycin. That is the latest thing. Earlier, we were using erythromycin-based measles vaccine, but recently we have started using MMR vaccines. That is containing the neomycin. Just remember this. So apart from MMR and varicella, we can also have the IPV vaccine, injectable inactivated polio vaccine, which contains neomycin. Gentamicin is one antibiotic which is there in all the influenza vaccine. The erythromycin I told you earlier we were using in the measles vaccine or the measles rubella vaccine, but now recently it has all been shifted over to the neomycin. Streptomycin and neomycin combination is again used in inactivated polio vaccine. So different formulations are there. So either they can be neomycin or neomycin with streptomycin. IPVs are there. So different antibiotics are there. So people who are allergic to any specific antibiotic, they cannot use these particular vaccine. Specifically talking is commonly asked about MCQ about neomycin. Neomycin allergy is not there. It is a contraindication for measles vaccine or the measles rubella vaccine. Also, neomycin allergy is contraindication for the IPV vaccine. Neomycin allergy is contraindication for IPV vaccine. So with that, thank you so much for watching this module. See you in the next one. Bye-bye.
Hi guys, please subscribe my channels.